patient with a reversible etiology. Now, if with conservative management, if hemodynamics are deteriorating, now hemodynamics, I mean in terms of hypertension, in terms of cardiac index, and most important is in terms of the other organ dysfunction and the metabolic parameter derangement. So no, it should not be based on a single parameter, but probably it should be based on the multiple parameter. If in a patient of cardiogenic shock, there is progressive deterioration of metabolic parameter, lactates are going high, the recommendation is more than 2. The cardiac index is again less than 2. Some people they take 2.2 also. And unexplained organ failure. Suppose patient is developing new onset AKI or worsening organ failure, then probably that is the time the ECMO team should be alerted. The ECMO service should be provided. That's what is most important. Apart from there are so many other things we have to see, the age, feasibility, and the financial angle as well as we need to see. But in the clinical prospect, this is what is the recommendation from the also regarding the VA ECMO. On the other side, when we talk about the respiratory ECMO, unlike previously, so the recommendation was like you have to try proning, then recruitment maneuver, and so many things as a last resort to go. But probably over time, the ECMO community has realized that it should not be that delayed. Now you try proning. There are indices showing proning success failure. Suppose a patient's previously people were depending upon hypoxemia improvement or ventilation improvement with proning as the sole marker of the proning success versus failure. But recently, the if your patient on proning on first or second proning, suppose the driving pressure is constantly increasing or it's not coming down, then probably that's an indication to consider at least. So this is what the recommendations are slowly going towards like the little earlier. It should not be that delayed to allow the organs to go in irreversible phase of organ failure.
Got this. Thank you for that answer. And as we move ahead, so my next question would be to Dr. Vinod. We often debate whether ECMO is being started too late or sometimes even too early. The concept of timing versus judgment remains a gray zone. So, are we missing the optimal window for ECMO initiation, and should its use be protocolized or remain guided by clinical judgment, as explained by Dr. Niranjan? Or has ECMO already transitioned from a rescue to an integrated real early support modality?
Unfortunately, we don't have the clear-cut answer. So at present, what we are doing is it is a hybrid mode. It is the protocolized as well as the clinical judgment. Why we are using this? Because ECMO in the form of actually evaluation, and it is evolving what are the type of indications. If we talk about the indications for ECMO, mostly it is the individual based. Although we have all the criteria like the ELSO criteria, PF ratio, as Dr. Niranjan told, and also the irreversible cardiac failure and cardiogenic shock. But the thing is that the patients are so complex is that the only protocolized is going to have problem with us. That is the one thing. Second, these patients deteriorate very fast. So if you are using a protocolized manner, maybe at some period of time or some instance of time, the patient is not fulfilling the criteria. But even after, if you look at the patient after 1 or 2 hours, you will find that the patient has rapidly deteriorated. Right. So what I feel and what most of the intensivists and the ECMO people is the hybrid mode. For the indications I'm talking, only for the indications. Now, if you talk about the other part of the ECMO, like anticoagulation, ventilator treatment, weaning, and all those things, these are mostly protocolized. Anticoagulation is the most important, which is being used in protocolized manner. And although many times depends upon the individualized patient's need and other factors, but mostly it is protocolized. Indications still are in a hybrid mode. We assess the patient clinically. We are utilizing the ELSO criteria for refractory ARDS, for refractory cardiogenic shock. I'm talking about the ECMO where we are using for the reversible disease. not for the where the transplant is the destination. This is not I think the discussion point. Mostly it is the reversible diseases where we are using ECMO in terms of indications as a hybrid mode. The second part, as the ECMO has already transitioned from a rescue, this is already has been done, and it is now a privileged treatment. It is a life support, and no patient should deny it if the patient has got indications for ECMO. We know that if you don't put the patient on extracorporeal support or extracorporeal life support, the conventional treatment merely is not going to save the life of the patient most of the time. So, to my opinion, it is already transitions and already in terms of the indications, hybrid mode, clinical and the protocolized, and it is evolving as a life support whenever required. The patient should not be denied.
Yeah, very nicely put it across, sir. So, as we move towards ultra-productive ventilation strategies, Dr. Nicholas, so combining modalities is becoming more important, as we also understood from the discussion about Dr. Vinod put it across, but also they are more complex. So, what is your perspective when you talk of the prone ventilation? Because on one side, we uh, talk of resting the lung, and another side while doing ECMO, and on other perspective is proning the patient during ECMOs. Do you think it's thought to synergize with the ultra-productive ventilation? It improves the outcomes. What is your perspective on this strategy?
Lovely. Thank you very much. A really interesting topic and a very topical question. So I think the first thing to say is prior to ECMO. We've already heard two lovely commentaries on thinking about what to do beforehand and the timing. One thing I would add is proning before. I would consider almost universally appropriate, unless there is a clear contraindication to proning. Once you get onto ECMO, though, it's a little trickier. So there is some evidence in this space. There are two studies, both prospective randomized trials, where in both they went onto ECMO and then proned. In one of the studies, which was the study from Paris, there was absolutely no benefit. But this has to be looked at in the setting of the study. It happened to coincide with the COVID pandemic, and as it happened, all the patients had been proned prior to going onto ECMO, and there was absolutely no benefit associated with it. They didn't show any increase in significant adverse effects, though. So on the one side, it's safe, but on the other side, particularly if you've already been prone to no effect and you have COVID, it was of no benefit. The other study looked marginally more positive, but didn't reach statistical significance in terms of any benefit. Did not have as large a number of patients with COVID, which was a huge boon. So I think that where we are at the moment is, I would say, probably not immediately at the beginning, particularly if the patient has already been proned and has failed proning. I think that there is a real question, though, around using it later on in the course, particularly for postural drainage and physiotherapy. And I think the other thing that you asked was the practical challenges around it. And that is the act of turning the patient over safely and maintaining them in that position. I tend to use mainly femoral ECMO. Yeah. And for that, it's very helpful to dress the cannulae down the inside of the thighs so that you can avoid pressure areas. And underneath the cannulae, the nurses place duoderm or another very thick layer to protect the legs from pressure from the cannulae. So I think that's a really important point if you're going to do it. Clearly, doing it in a in a way with all of the staff around, so that you've got plenty of hands, so that you can do it safely. One person controlling the pump, one on the tubing, one on the airway. I have found prone positioning patients with neck cannulae a little more tricky, only because of the positioning of the head as you turn it from side to side. It can be awkward not to kink the loop if you've got either a single lumen or dual lumen cannula. So pressure area challenges, movement challenges, airway challenges are the biggest challenges. The question of benefit, it may well be there, but the evidence is yet to be clear.
Yeah, thank you very much. Anyone has different perspective over here, or all agree to this? Arpan, Dr. Vivek. I believe you all agree to this. So we'll move on to the next question, and that is to Dr. Vivek. So we all talk about the trauma brings a completely different physiology and set of risks for our patients. So what are specific differences and challenges when we using ECMO for patients with severe thoracic trauma, and especially when the bleeding and anticoagulation is concerned?
Thank you, Dr. Bharat. The first thing, the challenge comes because the trauma patients behave absolutely differently. And when we talk about in particular with the chest trauma, so it may not be just a single trauma that patient has developed ARD.
Yes.
It might be a myocardial injury, probably a myocardial stunning. There may be some pericardial effusion, hemothorax, there can be pneumothorax, so many other things.
Thanks.
And even injury to the mediastinal organ. And these patients are usually in the SIRS, and putting them on VV ECMO if we are facing of ARDS, which is unresponsive to our ventilatory strategies, will aggravate the systemic inflammatory response. So mentally, we have to be ready with that.
Right.
If the patient is having a pericardial effusion because of trauma, a reactionary effusion, so the moment you put these patients on ECMO, there will be some thirst and there will be vasodilatation. They may develop a hemodynamic instability immediately. So you have to be careful for that. Might be if it is leading to tamponade, you have to drain those. And definitely, anticoagulation is always a challenge because you are worried about bleeding the moment you start. So, truly speaking, this is no more a challenge. And in fact, the use of ECMO is very frequent in the trauma patient, where we can run for even weeks a VV ECMO without use of heparin. Because your flows are adequate, you are monitoring these patients regularly, and you are looking at the trend of various pressures, the delta P and other pressures. So you can run these, you are maintaining a good flow, ECMO flow, so that will prevent the clotting of the site. Maybe sometimes there is these oxygenator get clogged, so you need to change the oxygenator in those situations. But it can be run easily without the use of heparin. So, but this is not the only challenge. Trauma itself, because already patient may be hypovolemic, you have to look from that perspective before putting these patients, because hemodynamics can be a challenge. Even patient has a severe myocardial dysfunction because of trauma, so probably may not be just a VV ECMO may be adequate. You have to think of putting these patients on VV ECMO if there is a severe myocardial dysfunction, and that is leading to increase in the lactate levels and rising inotropic and vasopressor supports and not maintaining hemodynamics. Then possibly you have to choose the right modality for a particular patient.
Yeah, very precisely. Yes. Anyway, very precisely put it across. So there's also a growing shift towards minimum sedation and avoiding intubation also in certain cases wherever possible, even in ECMO patients without patient getting ventilated. We spoke of the prone, so here we're talking about awake ECMO. The patient might not be even ventilated. So Dr. Arpan, this is for you. So does awake VV ECMO truly reduce complication of invasive ventilation, or is it limited to highly selected patients? And then how do we choose a patient as well? You're just not ventilating the patient and someone on HFNC deciding to go ahead with the ECMO.
Thank you, Dr. Bharat. First of all, I should say this awake ECMO is a myth.
Yes.
At first time, you should not talk about awake ECMO because awake ECMO has two conditions, whether it's an awake extubated ECMO or awake non-intubated ECMO. You have never intubated a ECMO patient, that is known as awake non-intubated ECMO. It has two clear-cut indications to us. Otherwise, they are detrimental. if the patient is waiting for the lung transplant and if the patient is severely immunocompromised. These two category patients, you can try awake ECMO, even then with a pinch of salt. But in ARDS, it's detrimental. In one study during COVID in Chicago, they have shown some benefits of awake ECMO. Otherwise, we have miserably failed. Why? Because in acute inflammatory stage of ARDS, if you do them awake ECMO, they continue to breathe faster, they have larger tidal volumes, they are going to increase the PCL. And we have seen, you have put the ECMO on day 2, and the patient is awake, and ultimately you have intubated that patient on day 4 because of severe respiratory distress. Patient is having abdominothoracic bleeding, bad breathing. Patient is delirious. The encephalopathy is there, and patient is hypoxic because when he is awake, his cardiac output is reaching more than 12 liters, 13 liters, 14 liters, and you are giving only 5 liters of flow. So he remained hypoxic throughout the period of awake time. So we are not recommending any awake ECMO during the first phase of ARDS. What we can do, you keep patient paralyzed, you continue to do ECMO. If there is a signs of improvement in the second week, third week, when the inflammatory part of the ARDS has gone, patient is otherwise doing fine on pressure support, on ventilator, you can extubate if you don't want to take out the ECMO. So, and the question of ECMO versus ventilator removal also comes. Most of the centers, they do take out ECMO first, but it has its own limitations. So in ARDS situations, and also the patients on VECMO with a bad lung, these are the patients also where awake ECMO should not be tried. But only 2 conditions: waiting for the lung transplants, where the patients are waiting for the lung to get, and you want to really reduce the infective burden, and few immunocompromised patients. These 2 categories where awake ECMO from the primary, awake non-intubated ECMO is preferred. Otherwise, in our day-to-day bread and butter work, which is the acute ARDS situation, there is a big no to awake ECMO. Next is when you are practicing awake ECMO in the latter part of the ARDS, you have to think 2 things. When you are extubating the patient is free. Patient can 1 second pull out the cannula. This will cause severe, it's a catastrophe. Second thing, patient might again land up in doing PCLs and lot of self-inflicted lung injury, which might actually make the patient going back to the same situation. So be very cautious about awake ECMO and practice it along that way. So these are the key technical and patient related challenges for managing awake ECMO. For the beginners, for the centers who is starting, awake ECMO is a big no. If you are very well trained, your staff is looking the patient, you have a good 2:1 nursing who can take care of the awake patient on ECMO. Patient is completely fine. His sensorium is fine. He is not agitated. He is not tachypnic. Probably you can try awake extubated ECMO.
Yeah, so very nicely and crisply put it across, because as you spoke, it's a myth. We think it can be done. So we have spoken and heard of the situation where it was tried in the first stage of ARDS. So it was a kind of answer which was required, and thank you very much for Dr. Arpan. So now,
So
yeah, Niranjan, yes.
I have one more point to add on it.
Yes,
So I completely agree with Arpan sir. Now, maybe once upon a time, we believe probably the best way to give rest to the lung is to extubate the patient. Now we have data near about probably in 22 patients we have extubated, and of course the sample size is not that great. But in 22 patients, what I observed, quite a good number of patients, even if the hypoxia is improved, even if the hypercapnia is improved, still they remain tachypnic. That is a concern. Now the reason might be it's because of the stretch receptors. That is what we felt. Probably the some receptor in the lung which gets stimulated. They are independent of the hypoxia or hypercapnia. That's so they subsequently they went on ventilator. And those patients who require a reintubation, their outcome was not very great. That's second thing. What we observed, if we remove ventilator, we are completely blind about what's happening to the
Mechanics.
transpulmonary pressure, what's happening to the lung dynamics. We have to exclusively depend upon the chest X-ray. We cannot do CT daily.
The mechanics are not seen.
Now, yeah, this is the mechanics. Now we are completely driven away from the mechanics. That's what we observed. So from the routine practice of extubation, now which we shifted to, it's better to do a tracheostomy and keep them on ventilator, so that we'll get an idea of what's happening to the plateau, what's happening to the transpulmonary pressure.
Yes. So very, I mean, this is what he meant to say. You do it only when you're very sure about the condition getting improved. Otherwise, your patient is going to worsen because you'll add on to the silly, which eventually comes with the high respiratory mechanism could be something else. But eventually, the patient who gets reintubated, outcomes are poor. So we'll move ahead, and as we talk of the ECMO, we also talk of the ECMO and the organ donation. Niranjan, this is for you. So this is a medicine intersects deeply with ethics, logistics, and societal responsibility as well. So how do you view the use of ECMO in organ donation, especially considering the situation in Indian scenario, and what are the key considerations when performing apnea? Because this is also a question how we do apnea on the patient, because in the Indian context, we have to prove brainstem death, and apnea is very important component. So how do we do in the ECMO setting? So question one is use of ECMO in the organ donation. Two is how do we conduct apnea?
Well, we are in less of complication. The reason is the DCD is not allowed in India.
No, it's allowed now.
So yeah, and then now here and there
it's Maharashtra has done 18, and there are
yes.
many others as well. Yeah.
In few states, of course, in my state, in Odisha, they are recently they allowed, but by and large, DCD is not allowed. That's one thing.
No, we don't practice. You can put it across. We don't practice.
Yeah, we don't practice.
Yeah.
Yes, we don't practice.
Yes. Sir.
Now, ECMO has a very good role in DCD patients. Okay, that's what every across the world people propose. So simple thing: run a VA with an IABP inflated somewhere in the near the arch of aorta or just beginning of the descending aorta, and easily the warm ischemia time can be very much minimized. That's what is the concept after DCD. We understand we will be waiting for the legal permission we get, and probably that I feel that will be a very good use. One thing. Now coming to the DBD, brain dead patients. So two kinds of thing. One is the ECPR patients in a less successful or the unsuccessful ECPR, or second thing, if a patient is already on ECMO, VA ECMO, and patient has cardiac arrest, the brain dead. Now, there are data across the world, and there is one study I like to quote. It came in Journal of Critical Care Medicine. Near about, they have collected, it is a retrospective analysis, 141 patients they analyzed, and the successful organ transplant and the survival after the transplant was significantly, it went from 36 to around 670%. So it has its role. Now, per se, for the ECMO usage for the brain dead, again, that is a question. Now, second question is about if a patient is on ECMO and we are suspecting a brain dead, now how to perform apnea. A lot of research are happening. Then here and there, people are trying to solve the puzzle. Now, to start with the VV, suppose a patient in the veno-venous, it is slightly simpler. People recommend to stop the sweep gas. Then after half an hour, you try to disconnect the ventilator and allow the carbon dioxide to build up and see if the patient is breathing. That is one. Again, it is not a very much protocolized. That's one thing, because many a times patient may not tolerate both removal of the sweep gas and disconnecting the ventilator. It is not that easy because the patient is on ECMO for some pathology. Now that is a big challenge. So many patients, we have lost patients with viable organs because of this test. But again, as a legal recommendations, we have to do. That's not standardized in India. Some centers they say modified apnea test. So that's I like to listen from others. Coming to VA in a veno arterial, that is still more further complicated. Now, there is no luxury to decrease the flow in a venoarterial because unlike venovenous, these are very sick patients. If we try to decrease the flow, then suddenly they'll develop complete cardiac arrest. From the brain death, they'll go to cardiac death and will obviously lose the patient. Now, some centers, they do like this. They run the VA and along with decreasing sweep gas, they add additional or the external carbon dioxide. They allow that allows the carbon dioxide to be built to the desired level, and they disconnect the ventilator and they check. But it's not uniformly practiced. That's what I came to know. In our experience, we have never done it, but people here and there do. Now, to summarize, the modified apnea test is it's not a standardized thing to be practiced across the world, and the centers are still coming. There are sparse data on this kind of thing. Would like to know from other experts like how or from Professor Nick how the practice is in UK.
Anyone else? Yeah, please come in.
Oh, yes. Yeah. So thank you. Yes. So in the UK, what we did was we agreed a legal definition of death using brainstem testing criteria on ECMO to help deal with this. We used the same principles that you've already talked about. So for VV, it's a matter of bringing the sweep down slowly, and in order to allow an apnea test to occur, in order to demonstrate the rise in CO2. There are some patients we can't actually get the sweep low enough to allow the CO2 to rise. And so for those patients, we just don't do an apnea test. And in the VA patients, again, we have a legal definition now, which includes taking blood gases from multiple different sites in the body, including the right radial artery or the right brachial, as well as the left side, to demonstrate as best one can that you've covered whichever bloodstream is actually providing the brainstem. So we found by working within the framework of the law and creating the guidance, it gave a lot more security to the teams looking after patients, and also enabled organ donation from patients who are receiving ECMO.
Thank you. Anyone else? So when you talk of the legalities of the DCP is very much legal in India. I mean, it was first practiced, I don't remember an exact year, somewhere around 1972 or somewhere around 80. And it's just we have stopped practicing it. So there's conditional DCD, unconditional DCD. I'll not go into details of it, but there are many states which are now practicing, and it's across the India. It's been legally allowed. It's just we have to adopt it and grow over it. But the apnea test on the ECMO, I mean, it's very nicely, precisely put it across by the Niranjana and Professor Nick, and this is how we should go across. So VV ECMO, I think, is quite a bit of easier one, apart from the patient being unstable. But VV ECMO, we have to work around things and look at it. Anyone else want to add? I move ahead. Okay. So as we move ahead, we talk of the pregnancy and ECMO. And Arpan, this is for you. So managing ECMO in pregnancy introduces a dual responsibility where every decision is going to affect two lives. So in pregnant patients, how do we balance maternal survival with fetal outcomes when considering ECMO? And question 2 is, should pregnancy push us towards early ECMO initiation? Add caution to the complexity. Do we need pregnancy-specific ECMO protocols?
So Bharat, thanks for picking up this topic. What we have seen in India, the number of peripartum cardiomyopathy or the myocarditis in the pregnancy is very much underreported. What we see, it is the tip of the iceberg. here and there you will find that this patient, pregnant patient, died after a cesarean section and all these things. Probably all of them, the 70 to 80%, will be because of this cardiac issues,
Cardiomyopathy.
and they are either peripartum cardiomyopathy or the something myocarditis or kind of some embolism. So we have to be very much particular, and in future, in near future, within 5-10 years, we will get more pregnant patients in our ECMO cohort. And we have become brave enough also to put pregnant patients on ECMO. If I consider myself for last 15 years of journey, in my first 5 years, I was never thought that I will put the pregnant patient on ECMO. Even I have to put 2 patients on ECMO. But now we are confident because we know it's as easy as to run ECMO in other patients with few precautions. Obviously, you have to take care of the fetus, but at the same time, the mother is also not that complex from the normal population. And probably you need to think one step ahead than in other patients. And I'm just speaking to you, proning in pregnant.
Pregnancy.
It has been written that proning in pregnant patient is purely safe and all these things. But I'll put a caution: if you have not adequate manpower and you are not sure, proning should not be practiced in that kind of centers in pregnant patients. Rather, you put in ARDS patients early ECMO on pregnancy. Second thing, in the advanced pregnancy, if you see the left lateral tilt, there is a chance of your anticoagulation issues with there is increased chance of DIC in the hypofibrinogenemia. These problems are there, but main problem is the increase in the flow, because pregnancy demands higher flows. So you have to give a good flow with a good cannulas and good position. So this you have to ensure. Now, coming to the fetus, a continuous monitoring of the fetus by CTG more than 28 weeks is recommended, and you have to continue that. And the cesarean section protocols are as good as in the non-ECMO patients. In either ventilated patients, you can do take care of your cesarean section at that point of time. But 2 things you have to keep in mind: you have to be ready with your massive transfusion protocol, and second thing, you have to be ready with the counseling with the relatives that the baby you might lose. So these are the 2 things. Otherwise, the outcomes are comparable. And if you see the patients, particularly in peripartum cardiomyopathy, particularly in any kind of myocarditis, in kind of ARDS, the outcome is very good if you can take that during that time. Only thing we have to identify, and probably we have to put them early on ECMO, because this particular disease is very much rampant, underreported, and it is killing of our own younger mothers who are about
Would have made it.
require 1 or 2 weeks of ECMO to survive.
Yes.
So this is my take on this. Pregnancy-specific ECMO protocols, obviously the higher flows with the anticoagulation protocols, with the left lateral tilt, these are the physiological protocols. But early recognition and probably 1 step ahead is required in pregnant patients.
So very nicely, as you say, in the pregnancy, maybe our triggers are, we have to be preemptive. Our thresholds of putting patients on the ECMO needs to be a little lower down, and maybe in certain cases we might not even prone and go ahead with the ECMO if the team is not competent and we don't have it there. Yes, thank you. So as we move ahead, and this is ECMO in toxicology, and this is Dr. Vivek, for you. As you said, your interest is also ECMO toxicology. So in toxicology, the reversibility of the disease creates a unique scenario, and raising the question whether ECMO is always necessary. So question to you is, in severe poisoning in ECMO, which is a true bridge to recovery, are we overutilizing it in potentially reversible cases? And if at all we have to use it, then which toxicological emergency are the ECMO most responsive? And how do you integrate ECMO with the toxin clearance, like strategies like dialysis and hemoperfusion?
Excellent. Thank you for this question to me. when we talk about toxicology, probably the ECMO in toxicology has changed the scenario in India for utilization of ECMO in last 15 years. When you say overutilizing in a potential reversible causes, I will say absolutely no. It is not the overutilization, but using ECMO at right time for a right patient. Because we understand that these patients who are severely poisoned, they will reach to the hospital, either they will die, they will not reach at all. There may be several reasons because severely toxin, they have been given severe poisoning, whatever the reason, whether it's suicidal, homicidal, or accidental. So if they are severely intoxicated, they might not reach to the hospital. But those who have reached, till the time they are reaching to the ECMO center, possibly it's already delayed because they have been treated at some hospital, they are being referred to the next, and this is what exactly practically happens. And it should be decided if the patient is stable, there is no need of it. But if the patient is worsening, not responding to as we follow for any other ECMO initiation protocol, that if patient is not responding and is worsening, then definitely ECMO is an option because we know that the toxin will be metabolized from the body after a certain time, depending upon the half-life of the particular toxin. And that will be the time then when patient can recover completely and you can remove the ECMO very easy. Now, coming on that toxicological emergency, it's different in different part, and that is why it is very pertinent in Indian scenario or in the Asian scenario. Because if you look at the Western data, it is only drugs, most of the drugs, cardiotoxic drugs, beta blocker, calcium channel blocker, other drugs, which are actually whether accidental or suicidal, whatever. But if we look at the Indian scenario, especially India and Pakistan, Asian country, then it is more of the pesticide, rodenticides are other very common. And where we started this ECMO is aluminum phosphide, which probably those who have seen these patients, they know the dictum used to be 20 years back or 25 years back. If somebody has taken aluminum phosphide, mortality is 100%. Excluding only those patients who had taken the expired tablets or those who have taken after putting in the water. Otherwise, mortality used to be 100%. And these are the patients. If I talk about the patient profile where we have done ECMO in these patients with a survival of almost 70%, is lactate in the range of 20 to 30. Bicarbonate, in spite of multiple administration of soda bicarb continuous infusion, bicarb in the range of 4. pH is most of the patient less than 7. Almost 30% patient required CPR prior to the ECMO. Many had the ventricular tachycardia or blocks because it has all kinds of ECG you may come across. And definitely hepatic injury and renal injury almost in 40 to 50% of patients. And they are on the at least 3 or 4 vasopressors with the highest possible dose. With the, if I say vasoactive inotropic score in the range of 150 or above. So possibly this category of patient we cannot treat with any other modality except putting them on VN. So this is irrespective. Why in poisoning? The basic dictum for managing poisoning is it is not the poison. It is the organ dysfunctions or the body, how body has responded to that particular poison that matters. And probably that dictum should be followed that when the organ is failing, that has to be supported. This is what we usually do. So both ECMO, if somebody has some inhaled toxin of something and it is leading to ARDS, definitely as per any ARDS protocol, we can put these patients on ECMO. But most of experience, what we have is with the ECMO. Now coming on your third part, that how to integrate. Again, depending upon whatever the toxin has been taken, because ECMO here, it's not only a reversibility, but ECMO can be used as a bridge to antidote also. that the biggest example is the digoxin. If somebody has taken digoxin antidote is first, it's not readily available and it's very short half-life and it's very costly. So patient, we know that if the patient is dystoxicity, it is going to throw ventricular arrhythmia, it will have a persistent cardiac arrest, will not respond to other therapy. Put them on ECMO. And then we can administer the antidote and we can easily come out, remove the ECMO in those. Or even in the paraquat poisoning, where these patients have the irreversible respiratory failure, then possibly the use of VV ECMO as a bridge to transplant. Though it is again challenging that after how much time it has to be done, because even the small amount of the paraquat in the tissue can lead to a fibrosis of the transplanted lung. So these challenges we have to look for those challenges, but yes, it can be used as a bridge. It can be used a bridge to recovery. It can be used as a bridge to any antidote or even bridge to transplant. Coming on the toxin clearance strategy, if there are two components we have to look for. One, whether the toxin is actually dialysable or not. If it is dialysable, definitely you can quickly remove the toxin and you can get rid of the load of the toxic substance. But even if toxin is not dialysable and patient is having a severe metabolic acidosis, that is going to damage your organ more. So in those situations also probably using a CRRT along with the ECMO can be very beneficial for correcting doing a metabolic correction in those situations. So it all depends on the situation when the patient has arrived to you. Suppose if it is too late to use these modalities like hemoperfusion or other modalities, it's of no use. It's better to put them on ECMO and wait for recovery of it.
Yeah. Professor Nick, what is your experience over there?
So we've found I think the most common toxins that we have are accidental or intentional drug overdoses, and particularly the cardiac toxic drugs. And we have found ECMO incredibly useful in those circumstances, particularly beta blocker or calcium channel blocker overdoses, where you know that with 3 or 4 days of support, the patient will be back to normal. So yes, very much very supportive of it. And my personal experience is really around the cardiac toxic drugs. Excellent therapy for them.
So here it is more of the pesticides and there is more of the calcium channel blockers and the beta blockers. Dr. Arpan, what is, Alphos, I know you do quite a bit about it. So what is you?
No, I'm the person who has never put ECMO in Selfos.
Oh.
Because Selfos is not available here. I don't know, this is a curse or this is a blessing in disguise. Selfos is not available. People don't use in the eastern part of the game. I got to 2 cases Selfos managed by other means. But one thing I must tell you, see, this pesticide poisoning, particularly in the western and the northern part of the India, is an epidemic. It's an epidemic. I was speaking to Dr. Vivek Gupta just to ask how many people are taking Selfos per day or per hour, like the suicide rate and taking these things, because this is an epidemic. And you have to have a control of these things, because younger people, they are breadwinner of their family. They are taking those things, and you have to give good outcome to them. And probably he has started doing these things from 2013, and he has made it very good outcome. Because when I was doing my MD in BHU, I have seen a lot of Selfos, and probably all of them died. So this is a kind of national emergency or kind of epidemic we have to address. So we cannot play away from that thing. So this is our kind of disease pattern or these incidents. We have to address it.
Dr. Vinod, Dr. Niranjan.
Yeah, Dr. Barret, actually, we have aluminum phosphate poisoning. And the beauty is that if you are putting timely V ECMO, it is hardly a matter of 4 or 5 days. And within 5 days, you can have the decannulation and patient will be all right. That's why it has changed the practice in the northern India and all over India. Because before that, if you have taken aluminum phosphide, that is the certificate of death. We all know that. And unfortunately, most of this poison is taken by the students and the young people who had failed the 12th or who has failed in some of the foods. So that's why, at least in the metropolitan cities, and it had changed the practice. And if people are, in fact, I'll tell you the story. Now, if the person is coming to the Gangaram hospital with the sulfos poisoning, they will ask you, sir, when you are going to put my patient on ECMO.
Oh, they are aware
People
of
are
it.
also getting aware that the only treatment which is going to save my son or my daughter is the
ECMO. Yeah. So they Google it.
this actually awareness has created by the ECMO Society of India among every
Amazing.
doctor. If you have a sulfos poisoning, and mind it, it is never in India overutilized. Because first the patient will get treatment to the local doctor, he will go to some small hospital because it is a medical legal case. They don't want to inform to the police. So local doctor, then smaller hospital, and then they will come to us. So it is always underutilized. And most of the patients with sulfos poisoning coming to us, they are landing up, Vivek also knows, ECPR. Because in casualty, while we are cannulating or while we are planning, the patient will get arrested. So far we have done at least 60% patient have landed up into the ECPR. But good thing is that good prognosis, good outcome if the patient has landed up on the time.
Niranjan, you want to add something? Oh, yeah, okay.
Like Arpan sir, I am fortunate. I have never seen a self-house poisoning in this part of the country as well. But again, there is one deadly poison, the paraquat.
Paraquat.
So
Yeah.
since a long time, so many medical societies they were writing to the Prime Minister's office to ban this molecule. Now I'll tell a story. So probably 2 years back, the agriculture minister's father was admitted over here, and after 2 days from his constituency, another young boy came to another room in the same ICU with paraquat poisoning. And fortunately, those families they knew this minister because they voted for him. So now in the counseling, they were kind of like they knew that there was a lobby to stop, but it didn't happen. So that time the minister was like, honestly, he was telling, look, the the pesticide companies lobby is so high that even the ministers can't do anything. That's a deeper thing. But fortunately, since last, I believe 2 days before in the national newspaper came, the paraquat is stopped at least in Andhra, Telangana. Yes, it is. We were really celebrating that the good thing that it is completely stopped. But in black market, definitely will happen because today evening I got a call for one paraquat poisoning. We were laughing that 2 days before they announced it's the ban, and how come today the guy consumed, and right now the patient is in ER in another ICU. So again, it's a quite like underutilized. We know this thing. Their journey is quite tough. Normally, the lower economic class people, the farmer, they take that to young people because of something they'll take and they'll come. The parents they will be struggling. These guys they'll go to renal dysfunction, then ARDS, lung fibrosis. Few they go to transplant, and that's a kind of a little horrible journey. So ECMO, yes, we have used a couple of patients. They require initially VV, subsequently they'll develop severe pulmonary hypertension. They'll develop recirculation. I struggled a lot for a patient. We changed to VVA for that patient, but subsequently ended up in a transplant. So again, different part of our country, they get exposure to different kind of poison. So this is the story.
Yeah, so here in Bombay, we are more like the Nick. We don't see pesticides at all. In my whole of education, I have not seen it apart from the OPC. What we have seen is the calcium channel blockers, beta blockers, and then maybe the paracetamol overdose. So yeah, we'll move on, and we'll talk to the Nick again about the ECPR. So ECPR perhaps is the most debated frontiers in ECMO today, where seconds matter, system defines outcomes. So are we defining the right patient for ECPR? Are we missing the critical window? What should be the single most decisive trigger to activate an ECPR pathway?
Yeah, again, another hugely area, and one where the evidence progressively grow, particularly in patients with cardiac arrest that is refractory to conventional methods. I think that the first thing to say is, if we're thinking about the right patients for ECPR, it has to start with patients who have had really good conventional CPR. Just wanted to check you can still hear me, because it looks like my screen's frozen.
Yeah.
Okay. Great. So really good conventional CPR.
We lost him. So anyone can take this off you till he comes back.
Yeah, he joined.
Yeah, you joined. Yeah. Hi, Nick. Hi.
Hello. I seem to be
we
back.
can hear you. Yeah, you're back. Welcome back.
Oh, good.
Yes.
Yeah, everything went blank a moment. Yes. So firstly, good conventional CPR and good no flow time. I think that's really important. A lot of the data from Paris really supported having a zero flow time as an improved associated with improved outcomes. Waiting is also really important. So not.
There's an issue with his network, I believe.
I think we do need the comorbidity.
We can't hear you clearly, Nick. There's an issue with your network, I believe. So let me move on to the next question before we have sorted this out. So that is for you, Dr. Vinod. You're back. Can you please?
Yeah, I'm back. Do you want me just to finish up?
Yeah, if you could, because we lost you in a beginning. In fact, I would request you to start over again, because there were too many breaks in between. We totally lost the flow.
Okay, I don't know what's.
So basically, you started with the
good conventional CPR and then ECPR.
Excellent. Yes, good conventional CPR is a great place to start. Followed by witnessed cardiac arrest with immediate CPR. They're really so important. Having even a minute or two with no CPR really does worsen outcome, and so you have to be incredibly precise with that. Getting in there early is also very important. We talk about having times of up to 50, 60 minutes, but the reality is we want to get in there as quickly as possible, particularly for our younger patients. And I think one of the really difficult bits is trying to understand what comorbidities the patient has, because oftentimes we don't know. We don't know what comorbidities they have, and so we just have to do the best we can in those circumstances. For me, the thing that really makes the difference is the time to starting the cannulation. And so what we do is for all internal cardiac arrests, in hospital cardiac arrests, if they've been going for more than 3 cycles of ALS with our resus team, they call us, because we know that it'll take us 5 to 10 minutes to get to the site of the cardiac arrest. And then we know we need to make a decision, and then we know we need to set up, and then we need to cannulate. So with the best will in the world, from the decision, from being called to starting, takes us at least 15 to 20 minutes. If you're in the community, I think the big challenge with community-based cardiac arrests is getting the patient to hospital in a timely fashion. And so the frontier, the area where the trials are currently looking at is, do we take the ECPR to the patient with mobile ECPR, or do we bring the patient to the hospital? Both are valid approaches. We don't know which is the better approach. We don't know which is associated with improved outcomes. We know this is where they have established in emergency department or in cath lab service. They can do tremendous things. You look at the Prague results, they're excellent and driven mainly by the ability to get patients into the cath lab really quickly from that city. But it doesn't apply to a lot of parts of the world, particularly where you've got a very widely distributed population. So for me, 6 to 10 minutes is the most important trigger to activate the pathway internally or externally. And we need to think a lot about the logistics of how we can get to the patient or the patient can get to us, but be very, very selective. The more selective that you can be around those initial case selection is important, and then add on a layer of physiological criteria. So if the patient has very low oxygenation, don't do it. If their end tidal CO2 is very low and they've haven't had significant pulmonary perfusion, don't do it. Lactate is a little trickier in my mind, but if you've got profoundly disturbed oxygenation and CO2, then you've probably not really had effective CPR.
So as per your personal comfort, the maximum low flow time, what you said, is somewhere around 6 to 10 minutes to inform and the unit, and then the unit can come over and decide whether to go ahead with or not with the parameters what you suggested. Yeah.
Yes, that's correct. Yeah, we try to do it as soon as possible, and it gives us a little bit more time to think, and a bit more time for the patient to in spontaneous circulation.
Thanks. We'll move on. In country like us, where resource allocation is real and passing concern, and ECMO is one of the most resource-intensive therapies. We all know about this. So, Dr. Vinod, in resource-limited settings, how do we justify expanding ECMO beyond conventional indications? And if you had to redraw boundaries of ECMO today, what would you expand and what would you restrict?
If you think about the resource-limited setting, we all know that there are three most important indications, and already we are discussing. One is if we are using as a breakthrough recovery, one is the refractory ARDS, then refractory cardiogenic shock, and third is the ECPR. These are the established indications to use ECMO, and whenever indications according to the criteria, if there is no contraindications. Now, if we are looking for the expanding indications, the most important area where the ECMO has been used more frequently is the management of the complex airway. Like many times, we have to do surgery of the airway, and then also we have to do airway interventions, and also sometimes difficult to impossible airway. So this is the one situation where it is expanding, and in India also there are so many case reports and all over the world, because it can provide, either you are using a VV or VA ECMO, it can provide the oxygenation and as well as maintain the gas, like removing the carbon dioxide. So this is one area where it has been very useful and cost effective also, because here the ECMO is very short time. Hours, one, maybe 4 hours, 5 hours, you're doing the ECMO and then you have done the procedure, and you can in fact decantate the patient. The second area where we are not using in India, but people are using, is the pulmonary embolism, where the patient has gone into the cardiogenic shock because of the pulmonary embolism, and there they are utilizing ECMO and also going for surgery and all this. Now, these are the two indications in my mind. Maybe some other indications like life-threatening asthma, where you can use if you are not able to ventilate the patient, but the extracorporeal CO2 removal may be a better indication than going to the patient for the ECMO. If we have to restrict, the three situations where I would like to restrict, one is CLD, chronic liver disease, and gone into shock. and ARDS we are not using, and probably there are few centers we are using as a bridge to transplant. The second, where that we know that if you are using ECMO in a neonatal or pediatric septic shock, the results are good. Unfortunately, most of the time in septic shock in adult patients, the results are not good with ECMO. So we have to think twice when we are considering using ECMO in patient who has got a septic shock. Third is again many conditions but I'd like to mention two. One, ARDS related to the ALF, acute liver failure. People have used, they have failed, they have not succeeded. And also ARDS related to the acute severe pancreatitis, because ECMO requires a lot of fluid. It can cause massive rise in the intra-abdominal pressure, and it is not possible to run the ECMO in acute severe pancreatitis. Similarly, acute Dengue syndrome, whether it has manifested as ARDS or dengue shock, the outcome with the ECMO is very bad. Again, what Niranjana has told, paracrine poisoning, again, if you are using ECMO, you have to prepare for transplant. ECMO is not the answer for the paracrine poisoning. So if you ask me to expand maybe complex airway diseases where we can expand it for the short term, restrict septic shock, ALF, CLD, paracrine poisoning, even the patient has gone into cardiac or the refractory ARDS, I will restrict my use in such type of patients. That's what my feeling. Yeah.
Very nicely put it across. Anyone wants to add something? So we'll move ahead.
Yes.
And yes.
Yes, Dr. Bharat. Just
Yeah,
want
please.
to add what Dr. Vinod said, absolutely correct. But my take will be what I would like to restrict. I would like to restrict the cost of ECMO so that I can do ECMO in more and more patients where it is really indicated. Indications, Dr. Vinod Singh has nicely put across, but restriction has to be caused so that more patient can be benefited, because we are just doing ECMO in as a tip of iceberg. There's a lot more patients who really need ECMO support, but we are not able to do because of several reasons. There are less centers, cost issues, logistic issues, so many factors. So that is the only thing I wanted.
Yes, Arpan, please.
So just because this is the last slide, is a very important slide, because we are actually in the talk in the town is Dikshit Bharat, and we are taking into our ECMO society, and probably the ISCCM also is into that. So this six category of patients has to be taken on an urgent basis for the ECMO run, like in young ARDS with an young trauma. Toxicology patients, as I have told you, probably the northwestern part of the country is requiring ECMO even at the rural level. Pregnancy, this is the tip of the iceberg. We should protect our young pregnant mothers from the top these perspectives. Pediatrics, exceptionally good outcomes. So we have to protect our kids. And the peri-procedural. These six category patients, we need to have a very aggressive, even in the resource limited, whatever you say, rural, semi-rural, urban, whatever it has to be protected in this kind of patients with ECMO.
Yeah, very nicely put it across. So once we restrict the cross, then it will no more be related to the resource limited settings. It will be widely used, and especially those indication what you put it across where outcomes are really very good, especially in those cases we should be using it. So thank you all to our esteemed panelists for such insightful and thought-provoking discussions. And what stands out today is that ECMO is no longer a technology, it's a decision-making ecosystem. It demands judgment, timing, teamwork, and above all, clarity of purpose. And this is what we understood. Thank you to everyone who joined us today. See you soon. Until next time, stay curious, stay critical, and keep pushing boundaries in patient care. Good night, everyone.